Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Dr. Gary Bernardini, the Director of Stroke at Albany Medical Center, and we have two stroke survivors, Eileen Schoch and Alexander Watrobski. Welcome to the show, everybody.
Thank you.
Dr. Bernardini, why don't you start, just tell me real quick what do you do at Albany Medical Center?
I'm the Director of Stroke at Albany Medical Center, and so we have a stroke program, a stroke center at Albany Med, and specifically designed just to treat stroke patients.
Mm-hmm. And today we're talking about stroke. So let's talk about statistics and incidence.
Mm-hmm.
It's not a good number, first of all.
Yeah, it's not.
How many people per year in the United States? 750,000?
Right, that's right, Peggy. It's growing, so as the population ages, there'll be more and more strokes every year. And as some of the statistics you might have seen, in 2004 it was 700,000, now it's 750,000 strokes a year. And if you look at statistics, every 45 seconds someone has a stroke, and every 3.5 minutes someone dies from a stroke. So it's a tremendous problem.
And my numbers are 160,000 Americans die per year.
That's
I
right.
don't know what it is worldwide.
Yeah.
And the number 3 killer,
That's correct.
and
Right.
one of the leading causes of long-term disability.
That's right.
That's pretty terrible.
Yeah.
Do you want to just talk about the different types of stroke that there are?
Sure. Most people think, well, strokes are actually two types, as you mentioned. One is ischemic stroke, which just means a blood vessel in the brain is blocked, which leads to lack of blood going to that brain, and that part of the brain suffers an injury and dies. And the other is a hemorrhagic stroke, where actually you bleed into part of the brain. And part of that hemorrhagic stroke is divided into two, which is one is just bleeding into the brain, another is rupture of an aneurysm that sits in the brain. So, and those bleeding type strokes only represent about 15 to 17% of all strokes.
Okay.
The other, which are the ischemic, the majority of strokes, or about 80%, are the blockage of a blood vessel going to the brain that deprives the brain of nutrients and oxygen, and that part of the brain dies.
Okay, the major risk factors. Obviously one that I think everybody hears about is high blood pressure.
Right.
So obviously high blood pressure has to be controlled.
Right.
What are the other risk factors?
It's a very common list if you either have a heart attack or stroke, and it includes blood pressure you mentioned, diabetes, smoking. Elevated cholesterol can be an independent risk factor. Having a history of stroke in a family member at a young age puts you at an independent risk of having a stroke. Smoking certainly is a big risk factor. Smokers who stop smoking within 5 years, their risk goes to 0 of causing a stroke, so it benefits anybody who's a smoker to stop, both a heart issue and a brain issue. So those are the main risk factors, and we like to think of those risk factors, except for the heredity, as heredity issue is they're preventable. So these are treatable, modifiable risk factors.
Okay, and there's an element of risk that has to do with African Americans. They're much higher risk
That's
of
right.
stroke.
That's right.
I mean, I read some numbers. They're saying they have twice the risk of first ever strokes, higher death rates, and I guess more of a prevalence of high blood pressure, obesity, and tobacco use.
That's correct. All the things that you mentioned are absolutely true, and a lot of studies are looking into that. There's a study out of Columbia Presbyterian Hospital that looks at African Americans and Hispanics specifically, looking at their risk factors, and they are higher, and African Americans have a higher death rate from a stroke, and along with that goes higher incidence of hypertension, which seems to be a main risk factor in that population.
Okay, so what about prevention? How do you think, if someone knows that they have risk factors, how can they prevent a stroke from happening?
Just make sure those risk factors are controlled. My sort of joke and tongue-in-cheek thing to my patients is a little bit of high blood pressure is high blood pressure. So if your blood pressure is 150, which is high, it's not a little high, it is high. So preventing all those risk factors and working through your primary care doctor, treating all those risk factors can really have an impact in preventing that stroke that you don't want to have.
So obviously not smoking. What about exercise? Should
Exercise
there be
is-
regular exercise?
Yeah, I think so. I think exercise is good overall for well-being, and it certainly helps. Exercise per se won't decrease the stroke if you still have those other risk factors. So it's really looking at those basic risk factors and controlling those.
And what about for the patients that have diabetes? What do you suggest for them?
Just do the best you can in controlling your blood glucose and making sure that you check your finger sticks and making sure that you're well controlled. See your doctor regularly. You have, it's sort of the ball's in your court. You have the opportunity to take care of yourself and make sure your diabetes is controlled. That'll really prevent all these complications down the road.
Okay, so let's talk about warning signs. I know that we've seen the commercial on television, FAST, F-A-S-T. So why don't we talk about what the warning signs of a stroke are?
Sure, and I like that commercial a lot. I think it really is. It's not oversimplified, but it does get the point across of what you should look for risk factors. And really, for a risk factor, it's any new onset of symptoms such as numbness or weakness on one side of the body. And the FAST commercial talks about face and arm being weak or clumsy or drooping face.
Drooping,
Speech, if you have slurred speech. If you feel you can't walk, you feel like you've lost vision in one eye or you get blurry vision, or even a headache is included, although not in the FAST eponym, but headache is included. A sudden onset of headache, you should get to the hospital right away. And what's nice about the FAST commercial, the last part is time, is that make sure you know when the time of the symptoms were, because it's very important when you do get to the hospital to getting the appropriate treatment. Because now we have all our what is called acute therapies within the first couple hours. It's all based on time and knowing when those symptoms began.
So just so we're clear, I mean, I want people that are watching to know exactly what to do when they think that these symptoms are occurring.
Right.
Obviously, they can't drive themselves anywhere.
Don't suggest that. We suggest simple. Pick up the phone, call 911. Don't call your primary care, don't call your cousin, don't call anybody. Pick up the phone, 911, because the ambulance will be there and take you to the hospital. That's the fastest way to get to the care that you need.
Okay, so what happens once they get to the hospital?
Well, at a place that's a stroke center, such as our institution, a patient will come in and they'll be met by the emergency room staff. They'll suspect the patient has a stroke. And then at our institution, a beeper will go off to all the attending stroke neurologists and staff, and so we know a stroke patient has come in. That alerts us that we need to mobilize everything. That patient will get a CAT scan of the head to see if it's a hemorrhagic stroke or a non-hemorrhagic type stroke. And then based on the time factor we talked about, a decision will be made of how we can treat that patient with one of the therapies that we have.
And do you want to just mention the therapies real quick?
Sure.
I know that TPA has been a big one.
Right.
But
Yeah, intravenous TPA, which is given by vein, we have a 3-hour window, which is a very beneficial therapy. But at some places, such as our institution, Albany Medical Center, we have other therapies, some clinical trials that actually push that window out to 10 hours for treatment. So if we know a patient had a stroke within, say, 6 hours, and just to mention the TPA is a 3-hour window. If they're outside that window, we have other type therapies outside that window now to treat a stroke. So we're always asking, what time do the symptoms start? Do we know precisely? It makes it tough if it's a wake-up stroke where someone goes to bed, they're fine, they wake up with symptoms. We don't know exactly when the stroke began, and that makes it harder to treat.
Right.
Yeah.
So what about recovery?
Usually the first stroke people recover. So the first stroke, there's a better chance of recovering, and that's why it's important to prevent a second stroke, because there's up to 2 to 3 to 5-fold increase of that patient not surviving that second stroke or going to a nursing home and not going home. But recovery is based on the size of the stroke, what other risk factors the patient might have had, how age is an important factor in how recovery is, And it's really individualistic. I can't tell from one person to the next, you know, same age, who will do well. It's sort of up to the person. But in general, a lot of people recover from their first stroke.
Okay, well, we are lucky enough to have 2 stroke survivors here. Alexander, why don't we start with you? Do you want to talk about what happened on December 16th?
Well, after I come out of Walmart, I get in the car and want to get out on the parking lot and go home to Watrobski. And that's when I bumped into a parked car. And then whoever it was told me I can't drive anymore. And I didn't even realize I was going in an ambulance until I woke up in Albany Medical Center.
So you had a few risk factors. You had atrial fibrillation beforehand, and actually you were taking Coumadin, which is a blood thinner.
Yeah.
Which I guess Dr. Bernardini could attest that Coumadin is a blood thinner, so it's interesting that the stroke happened. What side was affected?
Left.
The left side.
Vision and motion.
Okay, so you were taken to the hospital.
Yeah.
What hospital did you go to?
Albany Medical Center.
Okay. And were you there a long time?
I don't know, probably what, 2 weeks?
A couple of weeks, 2 weeks.
Okay.
Yeah.
And what did they do to you there?
That I don't know. Medication and blood pressure.
You know what they did to him there?
I do. Alexander came in after that 3-hour window, so we couldn't use intravenous TPA, and we have one of our clinical studies that actually uses what's called an intra-aortic balloon, which is actually a device. So he actually went to the angio suite with our neuroendovascular team and got this device, which is a balloon that goes through the groin into the aorta and is inflated there for just about 45 minutes. And what does that do? That increases blood to the brain. And so he was treated with that, and he actually did really well, much better than what we'd expect based on the MRI scans and the size of his stroke. And he really made a very good recovery.
So right now, you're walking
Pretty
well.
good, yeah.
You're using a cane.
Once in a while I'll take the cane to make sure I don't fall.
Uh-huh. Do you have any weakness or anything?
Not that I am aware of.
Not that you're aware of. Well, I got to say, you're looking great.
Thank you.
For how old? 82?
I'll be 83 in
You'll
December.
be 83 in December. Wow, that's great. Okay, Eileen, you're next. April 17th, 2003. Tell me what happened.
I was out working in the yard. It was early in the morning. I kissed my husband goodbye. He went to work. And I kept working, and then suddenly I felt that something's wrong. My ankle started twisting, and somehow I knew I was having a stroke.
So it was like you couldn't control your leg.
Right.
Sort of.
Right.
Okay.
And being obsessive compulsive, I guess, I took the garden tools, walked down the slope, leaned them against the garage, walked back up the driveway and up 8 concrete steps so I could sit at the top of the steps so that someone could see me, because I knew if I fell down or sat down in the driveway itself, I would be there for a couple of hours before anyone would see me. It's just hidden enough. So I listened, and I was still able to call for help to my neighbor, Tom, when he was leaving for work.
So how long were you sitting there?
I don't know.
Oh, boy.
Yeah. I know my husband left for work at 7:30, and I believe I was in the hospital by before 9, between 8:30 and 9. So anywhere in that window. I just don't know when it happened.
Okay, but you were taken by ambulance.
Yes.
Okay.
Yes.
And where did you go?
I asked to be taken to St. Clair's, and they checked me out, and they did, I think they did a CAT scan, and they said, we can't treat her properly. She needs to go to Ellis. And so they transferred me to Ellis.
Mhm.
And I was there for about 5 days in ICU. And then I was wheeled down the corridor, and I went to live at Sunnyview Rehabilitation Hospital for 5 weeks. And while I was there, they worked me hard and helped me with speech, with memory, with all aspects.
So was that what was affected? Your speech, short-term memory?
Speech, short-term memory, my whole left
The
side
whole left side.
is, and it still is, non-functioning. Well, it functions, but not at its peak.
Now you're
shall we
still
say.
able to walk
Yes.
with a brace.
Yes, I have a leg brace that goes halfway up my thigh to keep my knee from snapping. That hurts my knee, also makes me walk funny.
Mm-hmm.
I walk funny enough as it is. I don't need to add to it.
So somehow you and your husband had to learn to adapt
Yes,
to what happened.
yes.
And somehow your house has to be adapted, your kitchen, your bathroom, everything.
Everything. Grab bars. I have a flight of 13 steps up from the garage level of the house to the main living area. And when I first came home, I came home in a wheelchair, and my,
And you have a slope on the front of your house and
yeah,
need
my,
concrete steps.
they drove up the lawn and took me to the front door to get in and out, and my son-in-law had built a ramp so that I could get into the house in the wheelchair. Stubborn, I wanted to be able to step, and so I learned how to start doing that.
Good.
And then I had 3 steps going from the living room up to the bedrooms, and we put railings on both sides, my husband and I think my father-in-law. And then 2 sets of railings on the stairwell up from the garage level. And once all those railings were on and I had had enough therapy to be able to handle it, I was able to now go up and down and in and out through the garage. So that's my primary exit now, is going that way.
Alexander, did you have to do anything to your house to get you into it, or
Not that
adjusted it
I'm
all?
aware of. No, I don't think so.
Okay.
I had a handrail put added in the front stairway because I had 14 steps to go down and up to get out the front door. Back door's got 2 steps more, but that might be the height of the steps.
Dr. Bernardini, are there any medicines that these types of patients, I know they had 2 different kinds of strokes,
Right.
that they have to be on for, since from the inception of the stroke and afterwards?
Yeah, since there are 2 different types of stroke, so in Alexander's case, because he does have atrial fibrillation, Coumadin is a lifelong medication. It is very beneficial in reducing recurrent stroke or even first-time stroke. And making sure that those blood levels on the Coumadin are therapeutic is really vital. And then in Eileen's case, even though there wasn't, it's really whatever risk factor was there. And I know the smoking certainly has been taken care of. She stopped. High blood pressure hasn't been too much of an issue. And really just looking at those risk factors. Sometimes some of the patients that I see, not Eileen's case, but some people will say, no, I don't have high blood pressure, and actually when you go back and look, they've had high blood pressure for a while, and sometimes we pick up hints of that on an EKG, which looks at, the heart may be a little bit big from long-standing high blood pressure. So it's essentially just controlling those risk factors, but staying active is really important. Physically active, whatever milestones you've achieved in recovery, as long as you stay active, you can maintain that. Sometimes if you do an active rehab initially and then you decide not to exercise, you kind of fall off a little bit. So it does take some work to maintain sort of the level that these stroke survivors have achieved, which has been good.
I would think that their state of mind would have to be really great in order for them to be able to follow up and do the exercise and do the diet and not smoke, do everything that they have to do to keep this from happening again. Eileen, how do you keep yourself upbeat on a daily basis? I can tell you have this aspect of humor about you.
Well, it's not always the easiest job. I do try to see the positive of everything, but there are times that sometimes I get depressed. I remember that I used to know how to walk, and I used to walk all over our neighborhood in the mornings. Now I can't remember doing it. I know it happened, but I can't remember what it felt like. And I don't know whether that is a result of the stroke or I suppress the memory because of the stroke. So there are changes there. I try to do as much as I can. I've learned I get a special can opener to open bottles and cans. It goes down or whirs. It's lovely. You know, whether you have a stroke or not, you should get something like that. I position things in the house so that I can use them easier. But humor is very, very important for me. I just have to see the positive of things. And it carries through from when rehabilitation. And I think this is when I knew during rehabilitation that I was going to get into a position where I would be a viable part of society again.
So you have to tell your story about what happened with your therapist.
My therapist, Barb, was teaching me, what if you fall and you don't have your brace on? So we are in the therapy room. She has a mat. She tells me all the instructions of everything I'm supposed to do. What step here, when you fall, you turn over, you bring your knee, you get up on the mat and you twist and sit. Those are the instructions. My short-term memory wasn't as good as it is now. So I only remembered half of the instructions. And we got to the last one where I was supposed to, I'm leaning and over the mat, I'm ready to turn and sit, and I forgot that part. So I wound up spread eagle across the mat.
That's always lovely.
With my rear end in the air. And Barb goes, oh my. And that's when I lost it. And she pulled the curtain so that nobody would see me.
So you started laughing.
I started laughing. And it was just hysterical laughter. It was fun laughter. It was, I can't believe I did this. And we got me sitting up properly, but we were just laughing just because it was humorous. And finally calmed down, and I went off to my other therapy activities. The next day, I was in a group that we met with regular, and I giggled. And one of the other stroke survivors turns and points at me and goes, "You're the one." And it turned out that my laughter had been so contagious that everyone else in the room benefited. And so when I remember that, I remember that I need to laugh for them and for myself.
Right. I am a believer that a smile is contagious. And laughter. So I'm always trying to find funny things in life. So how do you try to keep humor in your life? Do you watch TV?
I open my mouth.
Do you watch TV, or
No.
funny shows or funny movies or anything like that? Tell jokes?
I listen to my husband. If I want to hear jokes, I listen to him. He's a very bad punster, and I just groan. Sometimes I try to pretend I don't remember what he means, but it doesn't work. How do I don't look for humor. I would say maybe it finds me, or maybe it is so automatic that I find it. I'm blessed that I still have it after my stroke, because some survivors lose a little piece of that ability to recognize and share humor with others. So.
Well, I'm assuming there's one part of the brain that where humor is sort of noticed or acknowledged, and if that part's affected.
Yeah. I also wear crazy clothes. I know I'm very good.
You're not
from the
looking very
knees,
crazy today.
From the knees up, I'm always a very prim and proper, so to speak, person. But when you get down to my feet, I wear socks because I have the brace up to the middle of the thigh. I can't wear anything else other than something like socks. So I said, well, if I got to wear socks, they're going to be crazy.
Good.
So right now I
Rainbow, multicolored.
have a multicolored striped. Right now I have the Wicked Witch of the West socks on. And just anything that is not normal.
Very good.
And I go into the local grocery store and they said, what socks today? They look for me. They look to check on what socks
great.
I'm wearing that day. And if they're subdued, they go, why are you wearing such dull socks? So.
Dr. Bernardini, I'm sure you could speak to the mental element in all of this, the cognitive, depressive element. Do you want to talk about that?
Yeah, it's very common, actually. I think in the stroke patients that we see, that I see, it's over 50% of people that have had a stroke have some type of post-stroke depression.
Okay.
And oftentimes it'll start immediately after the stroke. There's loss of function. Patient a lot of times realizes they've lost that function. This is out of the blue, they're doing fine and something really bad happened to them. So we end up treating a lot of these patients with antidepressants right away, so to sort of get them over that. And then a lot of people down the road, after a month or two, they're recovering, they're getting better, they're getting back into some usual, daily routine, then that tends to go away. So kind of at that point, sometimes we'll take the antidepressant away. The person doesn't really need it at that time. But
how common are they?
I mean, like I said, over half, 50%.
Over half take
antidepressants? It's over half have depression, and we tend to use antidepressants in as many people as are willing to take it, and it's okay with them that they take it, just to sort of get them over the period of recovery. And there's another component to this, which is some cognitive and memory issues, and we heard about that today. That's also an issue. So depending, and it may not depend specifically on your location of stroke, but people have personality changes, and they may have cognitive issues and processing issues, memory decline. So that all is expected to get better, but certainly can be affected by any type of stroke.
Okay, so we have to do a recap. Let's just talk about, warning signs. We'll just redo the warning signs
Okay.
again. Fast.
So speech changes, numbness, weakness on one side of the body, problems walking, vision problems, blurry vision, one eye, both eyes, or headache. 911, get to the hospital.
Okay, don't take yourself.
Right.
And don't call a taxi.
That's right.
And just to review the risk factors again.
Yeah, so risk factors would be diabetes, high blood pressure, smoking, cholesterol that's elevated, and those are the main risk factors. Certainly if you have had a stroke or TIA, that does set you up for having another event if those risk factors aren't tightly controlled.
Okay. Well, I can certainly vouch for our library's collection for follow-up information, books, art magazine articles. There is a website that we want to mention, which is, let's see, strokeassociation.org, which is the American Stroke Association, which has all kinds of information on that website as well. Thank you very much for coming,
Okay.
everybody. We had a very large group today. Thank you, Dr. Bernardini.
Sure.
Thanks for watching. We hope to see you next time on Focus on Health.
Welcome to Channel 17, the Town of Colonie Government Channel.